Okay, let me know if you can view it.
Yes, sir, visible.
Good, thank you. So we are going to spend the next 30 minutes or 35 minutes if we have bonus time talking about treatment of EGFR mutated non-small cell lung cancer. As you have all listened to the previous abstracts presented, 7 of them were all on EGFR. And these are my esteemed panelists. We have already have them here, except for a couple. And I think the lone surgical oncologist in the panel, Dr. Adesh, is still not there. So it's right now all medical oncologists. Great. So we had 7 presentations. 2 of them were trials comparing the addition of a monoclonal antibody, either a EGFR monoclonal antibody or a VEGF monoclonal antibody to an EGFR TKI. So cetuximab being added to afatinib and bevacizumab being added to erlotinib. So these were two trials on this combination. Then you had a real world analysis on the sequential effect of osimertinib following initial treatment with afatinib, and a cost-effective analysis of first-line treatments for EGFR mutated NSCLC. Then you had 2 abstracts presented at the ASCO annual meeting and the ESMO Congress, and the first of them was actually looking at a new molecule developed in China compared to gefitinib, and the other one was again similar to the previous study, combining bevacizumab to osimertinib here. It was ironical to me that in this abstract, the highlighted portion was the only thing which was science, and the rest was all conflicts of interest. That was really something amazing. I don't know if you see that too often or not. And the last one was actually on in the adjuvant setting, the evidence trial comparing icotinib versus chemotherapy. We've already had a session on that, so it would probably do justice to focus on the first line initial treatment of EGFR mutated unresectable, advanced or metastatic NSCLC, because 6 out of the 7 presentations were on that. So we are really very happy as clinicians when we get an EGFR positive report, whether that's a biopsy specimen or a cytology specimen, whether it's L858R or exon 19 deletion, the 2 commonest ones. But we now know that there are multiple ways how you could treat them. You could give them a first or second generation TKI, then look at T790M. If positive, give a third generation TKI, or if not, then they go on to the pathway of chemo first line and second line. Or you could give a third generation TKI upfront, look for CS7S at progression, give a first generation TKI, if not, again the same pathway. Or you could combine a first generation TKI with pemetrexed platinum. I think it was a wonderful trial led by Vanita and all of the team at Tata. There, maybe at progression, you could again consider osimertinib or go on to docetaxel. And of course, FLORA2 is awaited, third generation TKI with pemetrexed platinum. And then obviously, once that is done, you have just left with docetaxel. Here, of course, we haven't factored in combining VEGF inhibitors or looking at other resistance mechanisms. And basically, the big question is that if you combine different treatment modalities, is the 2 + 1 just 3, or is it actually more than 3? So it's important to look at the numbers. This is just a representation of the FLORA trial, very impressive PFS and OS, statistically significant. Or if you were to do sequential treatment, give a first generation later and third generation later, you would still achieve significantly better results, but maybe not to that level. And if you have data from second generation TKI followed by a third generation TKI, and basically it's not just one option. You have multiple options, and you have to take several factors into consideration. And this is just a representation of how, if you do different things, you would get impressive survival exceeding 2 years, even possibly reaching 3 years, and doing much better than the comparator arm. So now let's get into the panel discussion. So does any of the panelists can comment what you see here?
So there is a lung lesion that is there in the uh,
Upper lobe.
left upper lobe, right? And
Is it
and
is it visible?
left upper lobe one is visible, and there is some
Yeah.
fibrosis, something that is visible on the right side, kind of fibrotic thing, and right lower lobe, some basal changes are there with some nodules. I think that's it.
Good. Okay. Thanks. So basically, this was we all. This is a lung cancer, right? It's a spiculated nodule, more than 3 centimeters. But when we treat, we have to look at several other factors. This patient, incidentally, not just had lung cancer, he had severe emphysema, where you can see this, and he had pulmonary fibrosis. So, three smoking related diseases in one. But sometimes we have to look at the bigger picture. For example, in this patient's X-ray, you can see a pathological fracture. So we have to take into consideration several things. Let's get down to our discussion with the esteemed panelists. So we have the first case, a 46-year-old male with an exon 19 deletion, no comorbidities, ECOG PS1, no brain mets, significant symptom burden. He's willing to have chemotherapy, has problems with affording expensive treatment. And so I've just listed the several treatment options: first generation TKI, second generation, third generation, chemo plus TKI, erlotinib with the VEGF inhibitors, or any other which things you might have on based on the trial data. So let's start one by one. So I'll call Dr. Sunil.
Excuse me, sir. Dr. Jayant also joined now.
Dr. Jayant has also joined. Fine. Okay. Thank you. So Dr. Sunil, your comments, please.
Yeah, so looking at this patient, he is a young patient, 46-year male with no comorbidities. And if there is a financial constraint and is not affordable for osimertinib, I would like to go ahead with chemo plus gefitinib combination, TKI plus chemotherapy combination.
Perfect.
Yeah.
I understand. Makes sense, right? Dr. Mridul?
Yeah, same. The chemotherapy with the gefitinib combination will be my preferred choice in this setting.
Okay. So, Dr. Nandini, you
if the patient can't afford a third generation TKI, then gefitinib with chemotherapy, or if there's a trial which is available, any new drug that is being evaluated for EGFR.
Okay, great. Dr. Darshana? I can't hear you, sorry.
Hello.
Yes.
So my preference would be a chemotherapy-based backbone with a TKI, since he has a high tumor burden with a pathological fracture, or the third generation TKI.
Right. So we seem to be having consensus on the gefitinib, PEM-carbo, this thing, and Dr. Jayant has joined. So do you agree, or you have different views?
I agree, but now with generic afatinib available, maybe a second generation afatinib can also be an option.
Okay. So basically, all of you have just opted for gefitinib plus chemo, and Dr. Jayant said he might use afatinib. Now just let's change certain variables in this. So the PS is 0, symptom burden is milder, and can afford practically anything. Would anybody like to change the options?
Afatinib.
Afatinib, okay. And can you just also, if you are changing, please tell why you would choose that option.
So low symptom burden, exon 9.
Okay. And you want to reserve OC after that? I can't hear anybody. Is somebody speaking, or there's a problem?
The mic had an issue.
Okay. Great.
Yes, I would like to reserve the osimertinib after using the second generation afatinib.
Okay.
Yes.
Anybody else has a change in thought, or you are still going with the gefitinib plus PEM-carbo?
So I would prefer osimertinib, sir.
Osimertinib. Okay, so now we're starting to have divergence of opinions. Afatinib, osimertinib.
Yes, sir,
Okay.
definitely. Affordability, if it is affordable, that I would like to offer the better quality of life, better responses on a single tablet, and good tolerance too. So I think osimertinib is the choice from my side.
Correct. But for a young male with no comorbidities, 46, tolerance should not really be an issue, right? And the TMH trial did show that the OS achieved with the gefitinib plus PEM carbos was sort of comparable to OC, right?
Yes, I agree, sir. But again, the single pill and the quality of life, it does make a difference when you have to come every 21 days for a cycle, and that thing can also be taken into account, especially when the patient is affordable. Why not go for that?
Okay. Right. And so anybody else has any other change in treatment plan, or it's going to depend upon the patient preferences now in this case, because affordability is not an issue?
No, sir. So I agree with what Dr. Mridula said. Osimertinib, he's a young patient. We can offer better quality of life, probably also better. He has no brain meds, and osimertinib also has good CNS penetration. So if anything is, a patient can afford anything, probably give him the best in the first line itself. So osimertinib, like Dr. Mridula had said before.
Okay, great. Thank you. So let's take another scenario now. So this is a 78-year-old lady, metastatic NSCLC, exon 21 L858R, multiple comorbidities, PS2, no brain mets, a little bit of symptom burden. Not the family and patient herself is not willing for chemotherapy, but they have no issues with the, it has problems with affordability. So I've obviously removed the chemo choice from here because the patient had said no, and the other ones are listed. So let's start one by one again. Dr. Sunil.
So if affordability is not an issue, osimertinib will be my choice of.
No, right now affordability is an issue.
So then I would like to go with first generation TKI gefitinib, single agent.
Any preference between gefitinib versus erlotinib?
So I would prefer gefitinib. So it is tolerated better in these elderly patients. With erlotinib, the rash might be troubling, diarrhea might be troubling. So I would prefer gefitinib in this patient.
But hepatotoxicity is more frequent, even though it is the frequency is not great, but it is still higher with gefitinib as compared to erlotinib.
Still, sir, in practice, we see that these elderly patients do tolerate gefitinib well, and they have a disease control.
Right. Dr. Mridul.
So first generation TKI, gefitinib or erlotinib? Gefitinib preferred.
Good. Dr. Nandini.
So I agree with them. If the liver functions are not very badly deranged and otherwise, then gefitinib, first generation TKI, gefitinib or erlotinib, preferably gefitinib because of rash and diarrhea issues.
Right. And Dr. Darshna.
So I agree. Gefitinib would be my first choice.
And finally, Dr. Jayant.
Yeah, even I'm comfortable with gefitinib.
So again, a consensus on using first generation TKI gefitinib. And again, let's flip things. So instead of comorbidities, you have one, multiple, you have just one, just coronary artery disease, and there are no issues with affordability.
Osimertinib. Still, we choose osimertinib.
Anybody else?
No, I agree, sir. I think also osimertinib is the clear winner over here.
So what's your experience, or do you have any concerns about the cardiotoxicity of osimertinib?
QT prolongation.
Correct. And this patient has coronary artery disease. She's 78 years old. So would you do anything differently, or would you be comfortable giving standard dose of osimertinib?
Standard doses with frequent monitoring of ECG, initially maybe weekly, and for the first month, and maybe later bi-weekly, and then we can increase the frequency of monitoring required. But I think the dose I would like to continue the same, 80 milligram.
Okay. And any takers for erlotinib with any of the VEGF inhibitors? Doesn't seem to be a favorite right now. No, it's OC.
Yeah. So with VEGF also, the risk of the ischemic heart disease, the thrombosis, and it is there.
Yes.
And in fact, I think it will be definitely more because of the prothrombotic properties of the bevacizumab and ramucirumab. So probably, I think it will be difficult choice over here.
Correct. Okay. So I think so. Cost is the probably most important deciding factor. We have seen our panelists. Anytime affordability is not an issue, osimertinib tends to be the preferred drug. But in real life, I think 99% of our patients, at least, I believe TMH setting and my setting were probably just as same, though people will not be able to afford the only legal version of osimertinib. Okay, let's go to the third case now. So 61-year-old male, exon 20 L861Q, single comorbidity hypertension, PS0, no brain mets, moderate symptom burden, willing for chemo, but has problems with affordability. And again, we start with Dr. Sunil.
Here I will prefer using second generation afatinib. I would like to use looking at the mutation, and if affordability is there, may think of using osimertinib, but afatinib will be my choice in this patient.
Okay, good. Thank you. Dr. Mridul?
I would prefer Jefnib with PEM carbo over here.
Okay, any particular reason?
So basically, the combination, it works better. The same reason, no different than the other mutation. I think even this combination is also good. And if the patient has willingness, and although age may be one factor that is against that, he might have more cytopenias. But maybe this one is my preference.
So the TMH team is sitting here, right? So how many patients of uncommon mutations were there in your trial?
Very few patients were included in the study.
Right. It was still largely restricted to the common exon 19 del and L8 beta, right?
Yes, yes.
Okay. So the efficacy of the combo has not really been proven for uncommon mutations also, although you might theoretically expect it to work just as good or maybe even perhaps a shade less, right?
Yes, sir.
Okay. All right. So that was Dr. Nandini.
Yes, sir. So, considering the mutation afatinib had in the Lux Lung 3 and 7 pooled analysis on rare mutations, and this was one of the mutations that were included and did well. So, probably afatinib would be my choice, and if that is not an option, then maybe Jeff with chemo. But based on evidence, and in this case, and so our study did include about some 3 to 4 patients with this mutation, but a small number, as you said.
Correct. So that's not enough to draw any conclusion.
Yes, I agree.
Dr. Darshana?
Sir, afatinib or maybe just the PEM carbo without the gefitinib.
Why exclude the Jefnib? I mean, why not give an EGFR TKI to an EGFR mutated patient?
Because if it would be an afatinib, I would have included. I don't know whether gefitinib would work or not. And considering the age and the comorbidities, I do not really want to add to anything.
Well, just one comorbidity, hypertension, well controlled, 61 years, that's not too old.
But
That's the median age of diagnosis.
so I would try, but I mean, that would be my
Oh.
choice to
Oh. So at what
sequentially
point
use
of
it.
at what point of time would you consider an EGFR TKI in this patient? If you're going to use chemotherapy first.
Sequential maybe.
Sequential means when?
After after giving the 6 cycles of PEM carbo.
So you could go on to a pemetrexed maintenance.
Yes, but that was something which I would do, considering the 61 age group symptoms. And the
So,
affordability is an issue.
Mhm.
So
but generic afatinib would be cheaper than giving pemetrexed carboplatin every 3 weeks.
yes, sir. So that's what I said. My first preference would be afatinib. If not, then a pemetrexed carbo without the chefenib, with or without. I mean, no special benefit that I would get with an upfront chefenib.
Okay, all right. Good to have divergent views, Dr. Jayant.
Yeah, so this is an uncommon EGFR mutation, and afatinib has the most data for it, so I would go with afatinib.
Correct. All right. Again, let's flip a few things. Patient has brain mets, PS1 because of brain mets, down from 0, and no issues with affordability.
Mutation is same, sir, right?
Yes.
LS61.
Correct.
Here, affordability is there. I would choose osimertinib, or we can do whole brain radiation, and then afatinib will be my choice.
Okay. And how strong is the data for uncommon mutations with osimertinib compared to afatinib?
So,
There-
in one studies, the results are comparable. Osimertinib has shown the similar benefit like afatinib, but we have a more data for afatinib compared to osimertinib.
small phase 2 study with attempt by the authors to show that it is comparable to afatinib, but there is no denying that the magnitude of data which is available for afatinib is probably strongest for uncommon mutations. So why you have a lot of options now, right? You WBRT. So suppose the patient had one up to 3 lesions which are small. Could you avoid WBRT?
Yes, we can avoid. We can go ahead with SRS and then followed by EGFR TKI.
Okay. And and if you were to explain this to the patient that you have 3 small brain mets, we could give you afatinib plus SRS versus osimertinib. What would you weigh? Which one would weigh better?
So I would like to go ahead with SRS plus afatinib for the patients with uncommon mutations.
Okay.
Even if we are choosing osimertinib, I would like that patient to be treated with SRS, and then we'll use osimertinib.
Okay, great. Anybody else has any other opinions? Or
So if the patient is not very symptomatic and the mets are very tiny and it's not in any critical location which needs to be addressed urgently, I would probably avoid using WBRT if there is access to osimertinib. If the patient is going to live longer with the cognitive side effects of WBRT and other issues. If, of course, the met is symptomatic, it's a large met, or there is some critical structures or issues, then radiation will be required. Then it's definitely not a choice. But if I had a choice and the mets were tiny, then I would probably let the patient not get the side effects of radiation.
that's fine. So suppose the decision is not to give WBRT immediately and SRS is not available at a given center. Would you add steroids to osimertinib or not for a mildly symptomatic patient from brain mets?
So if clinically indicated, we would, sir, if the patient had symptoms, and probably taper it quickly.
Okay, good. Thank you. Let me just look at the time. I think we have another 10 minutes or so. So let's move on from this to the adjuvant setting. So I'm not going to discuss a case. I'm just going to get your opinions. So the first question is, would you ask for EGFR mutation testing with or without other markers in potentially resectable NSCLC in the diagnostic biopsy specimen? So maybe the TMH people can answer together and the others can chip in.
Yes,
Yes.
I will ask.
Yes, sir. Of course, we patients don't afford adjuvant osimertinib, but we would like to ask for these mutations.
Okay, indeed. I mean, the plan is to work up for surgery, get surgery, but even at the diagnostic part, you will ask for EGFR testing.
Yes, sir.
And is that the practice elsewhere as well?
So very like we haven't had such a scenario recently since these have been operated. But yes, I would like to include the testing.
Okay. And so the next question is, so that if patients are on NACT, you get the EGFR report, and what are you going to do? Are you going to use this combination of Gefitness plus PEM carbo, or you are going to use another TKI as the solo therapy, or you are just going to ignore the EGFR report, continue with NACT? How does it happen?
So we'll not include EGFR TKI in the neoadjuvant setting. We'll go ahead with chemotherapy only. We'll be concerned about use of TKI in the adjuvant setting.
Okay, so that's fine. So then, if you are not going to act upon the EGFR report, why would you get it tested? If the plan is to get a surgery and you will have the whole surgically resected specimen to do anything you want, NGS or anything, and you are not going to use an EGFR TKI in the neoadjuvant setting, why ask for the report?
So I think I answered for the adjuvant setting only, not for the neoadjuvant. So not for the neoadjuvant, probably for the adjuvant setting we would require.
Adjuvant is fine. I am asking, a patient is being worked up for surgical resection. Obviously, you have a diagnostic specimen which confirms NSCLC adeno. You ask for EGFR or you don't ask for EGFR?
So the rare situation is where there is a patch CR and no malignancy in the post-surgical specimen, which is not very common still, but it is usual practice that if we have a EGFR mutation positive, like we can get it done in the diagnostic specimen itself.
But the diagnostic specimen is remaining. So suppose you have surgery and it shows us pathological CR, you don't find any tumor. You can always go back, ask for EGFR or any other testing possible in the diagnostic specimen. Why at this point of time, while the patient is being worked up, if you're not going to act upon it?
So there are ongoing trials for neoadjuvant osimertinib. So if we could access like a patient who doesn't want to take neoadjuvant chemotherapy, we could probably like try to get them an access onto ongoing trials. That would be the current reason for getting it done.
I agree completely. I think so. The only reason why somebody who's potentially resectable, you would want any of these markers is to get enrolled in a trial if he or she is eligible. Fine. Now, the surgeon, there was one surgeon, Dr. Adeshi hasn't joined, right? Is he there? No.
No, sir.
I actually wanted to have their opinion. What would they prefer while operating for NACT versus NACTT? Anyway, let's skip that. So the question is now that we just have, I think, 5 minutes or so. So if it is pathological stage 2B, which is T1A to T2B N1 or a T3N0 or a pathological 3A, which is T3N1, completely resected R0, no lymphovascular invasion, no lymphangitis, no pleural invasion, no STAS. Would you consider an adjuvant EGFR TKI with chemo or after chemotherapy if no NSCT had been given?
So adjuvant chemotherapy followed by TKI.
Okay, so
yeah, like osimertinib, 4 cycles of adjuvant chemotherapy followed by osimertinib maintenance.
Adora, right?
Yes.
Okay, so that's the consensus, or anybody is going to think differently?
It's a consensus.
But if patient can't afford osimertinib?
Then we would explain to the patient that if they don't want adjuvant chemotherapy, then based on the CTONG data, geftinib, but with the explanation that overall survival is, there's no significant proven benefit of that. So preferably, if the patient is fit, we would counsel them to go for adjuvant chemo.
Right, so patient is fit, but has problems with affordability. So if you complete 4 cycles of adjuvant treatment, would you put the patient on gefitinib or erlotinib generic if patient can't afford osimertinib? I mean, these are the real life situations which we face, right, every day.
Sir, would like to put him on some first generation TKI maintenance. We'll have a discussion with the patient that we have a data for this drug which is very costly, and if patient is not affordable, we'll also tell them that these are the other options which can be used, though we don't have a strong evidence. So I would like to give him some TKI maintenance.
Okay. And suppose the patient had received NSCT before. I mean, basically it's a YP, 2B or 3A. And so would you use adjuvant EGFR TKI alone?
Yes, if he has received NSCT, then we'll use adjuvant TKI only.
Okay. Ullas has joined and wants to comment. Please, Ullas.
No, I want to ask a question. What would you do?
I'm the moderator. I'm not supposed to answer.
I am
you are an
panelist
expert.
here. I'm the audience. Audience
No,
audience can always
please.
ask a question.
Please tell what you would do or what you are doing currently.
No. You tell me what would you do?
No, same. I mean,
So will you give gefitinib?
Again, discuss the patient, can't afford osimertinib. I would not deny an EGFR TKI to a patient who has an EGFR mutation. So complete cisplatin based adjuvant chemo and put him on gefitinib, him or her. What's your practice?
I have a different take. I will not actually give gefitinib. I mean, again, the point is how long do we give? The toxicities of a single generation TKI, let the cost not be there, and the increase in the incidence of brain mets which are there with gefitinib. I mean, we have had patients. We have had 3-4 patients. We actually haven't given. People are doing fine, and have restarted people on the adjuvant TKI on palliative TKIs once they have come back. With the lack of OS advantage, I think. It's very difficult to, we cannot tilt the data whatever way it suits us. If there is an OS advantage and the disease and the drug is costly, we say drug is costly. If there's no OS advantage, drug is cheap, we say drug is cheap, let's give it. So I think that both the data have to be looked in the same way. So that is why I asked your opinion.
No, but brain mets developing is not because you are giving gefitinib. It is because you are not giving a drug which has good brain penetration.
In CTONG trials, there was a higher incidence of development of brain mets probably at the later part of the time, and that is also one of the reasons what they said why the OS was actually not better in the gefitinib arm. So my take, I mean, I would rather, if there is no OS advantage, I would not subject the patient to 2 years of an oral TKI also, which may cost us 5,000 rupees. That's my take.
So you would just put them on observation
And then wait and see what happens.
And so suppose the patient has a relapse and has a poor PS and you are not able to do much at that time versus if that question arises, had I started or had the patient taken a TKI at that point of time?
I will deal with that question. I will deal with that question at that time also and before starting the treatment also. And I'll again give an example. So maybe, the answer to a maybe is another maybe. Maybe if the patient relapses with one more small nodule to the opposite side and I give SRS or SBRT to that and then continue him on observation without any treatment, then also things are okay. The point is, Navneet, let's forget about EGFR mutant. The point is, you do not have an OS advantage, a documented OS advantage with one particular drug. Will we, just because the drug is cheap and it's easily available, should we be giving it? So my take is no. That's my personal opinion. I know I'm at variance with a lot of other people on this, but that's the way. If you look at science, you look at science.
That's fine. There is no data. The problem is in real life scenarios, we always don't have data, and so a lot of things are based upon clinician discretion versus discussing with patients what they want. I'm fine with that.
I'll ask you one more this thing. You have a patient of stage 3 NSCLC, CTRT given. It's a EGFR mutant or an ALK this thing. What would you do?
I know.
I will answer that for you. You send it to me. I have a trial going on, LAURA trial. I will put him into the trial.
Oh, that is fine, right? So we're coming up with ASCO stage 3 guidelines, and this was a very big point of discussion for stage 3 unresectable treated with chemoradiation, and you know the EGFR status. What would you do? Would you give put them on maintenance durvalumab versus TKI? So I think there are divergent opinions across the board here.
One more minute only.
They will
Pardon?
also shut up.
Only 1 minute is pending.
Okay, I am done.
Go
Actually.
ahead. Go ahead, Navneet.
No, no.
Go ahead.
I am done. So I think.
Okay,
I
so
would-
regarding one more point you raised, Navneet, was that whether we will do an EGFR mutation at the beginning of this on the diagnostic biopsy.
Mhm.
I think the one reason why we would do is if you want, you very rightly said, if you want to give immunotherapy to the patient. So even if you want to give chemoimmunotherapy, all the AGN studies and all have basically shown that there is, I mean, they're excluding people with EGFR and ALK. So that's one of the reasons why we would do a EGFR on the initial blocks. That's just a point.
Okay, so I just like to end by saying that what really matters is being able to test an oncogenic driver and giving the appropriate therapy versus not being able to test or finding something and not being able to give. This is for obviously for the metastatic setting, and I mean, you don't, I mean, TMH people, Ullas, nobody needs this. It's just for people who are still in training, that the aim is to test and treat if you find something positive, because that is what makes a difference. And obviously we are now going, nobody knew it, that even 2021 is going to be all about this. And we are soon going to move to an era where it is going to become more and more complicated. It's not just going to be the type of EGFR mutation, what is there along with it. And so let's hope we have the ability to move through this extremely rapidly changing landscape. Thank you.